Good morning, everyone, and welcome to this morning's webinar on embedding equity into emergency operations. We are so excited to have everyone with us this morning. This webinar is being co-hosted today by BARHII and the Alliance. To get us started, we're going to actually hand it over to the executive directors of BARHII and the Alliance, Melissa Jones and Tracy Delaney.
They led to partnerships that have 100% eviction moratoriums in place across the Bay Area to prevent a surge of new homelessness during COVID-19. They've led to webinars and learning series on new practices and models that we'll need, including guaranteed income programs to support people in this moment of reduced wages. And a set of strategies that are being played out now to make it easier for more basic income pilot programs to operate across the state. And they've led to programs like this one. We, as one of our core bread and butter pieces of work at BARHII, focus on the need to support equity infrastructure inside government. And this is perhaps a time more important than any other for that kind of infrastructure. COVID-19, as you know, has shown and laid bare many of the inequities that we've seen in health across our state for quite a long time. And I'm going to take you through some of that data in just a minute. Next slide, please. So here is the data from the state of California about why all of this is just so important. You'll see our early reports about COVID-19 talked about COVID-19 as the great equalizer. But the truth is that has not been true. The brunt of COVID-19, both the health crises and the economic impacts, have hit people of color and different ethnic groups differently. And you'll see here the number of cases across California by race, ethnicity, including the percent of cases in the Latino community, which is 38.9% of the population and 55% of positive test cases right now. And in the African American community, where the African American population here in California is 6% of the population and 8.7% of the deaths. And likewise in the Native Hawaiian and Pacific Islander communities. And so we know the impacts are varied by race. Next slide, please. And they're varied by race across age groups, and this just shows a bit more of that here. This is the moment where the Governing for Racial Equity cohorts who have been operating all across California for 4 and 5 years for the health equity policy units and for the health equity staff across health departments to be joined together in strategy, and we're happy to share with you this piece of promise for health equity work that has happened across the state of California and in other places, so that there are some models to draw from. We've done the work on this piece in partnership with the Public Health Alliance of Southern California, who's a longstanding and really important partner at BARHII. And I'm really happy to introduce Tracy Delaney to talk a little bit about who the Public Health Alliance of Southern California is.
Great. Well, thank you so much, Melissa. Good morning and welcome. I'm Dr. Tracy Delaney, founding director of the Public Health Alliance of Southern California. And we're a coalition of the executive leadership of 8 local health departments in Southern California, which together serve 50% of the state's population. We have a strong commitment to equity. I'd like to take a moment and thank everyone on this call for your tremendous dedication in public service during the COVID-19 pandemic. With so many critical and emerging issues, we know that it's easy to get swept up in the problem of the moment. And because of that, it's especially important that we proactively incorporate an intentional equity frame across our COVID response to ensure we're not only inadvertently not contributing to racial disparities, but even more importantly, so we can begin to reduce and eliminate these inequities. We know many of you have already begun the process of intentionally embedding equity into your emergency operations structures and response. We all know that COVID-19 has exposed both critical gaps in our public health infrastructure, as well as stark underlying health inequities that place low-income and communities of color at the highest risk. Throughout the pandemic, we have worked to identify and elevate priority needs for our local health departments and the communities they serve. To assist in filling these needs, the Alliance has developed a suite of tools and resources and is working to advance policy across 3 key areas: strengthening public health infrastructure, advancing equity, and addressing critical data needs. Next slide, please. This brief and webinar support the work we have done with our local health departments throughout the COVID response, including a series of equity snapshots, elevating emerging and critical equity issues that pointed early on for the need of a robust equity team and lens to be embedded throughout the official emergency operations structure. In addition, we've also launched an interactive COVID HPI resource map on our California Healthy Places Index platform to support local response efforts and to inform equitable resource allocation, program planning, and service delivery. And just as Melissa pointed out, the statewide disparities that we see in race and ethnicity, if you're able to jump onto our map, you can also see these localized at the county level for death rates for race and ethnicity. And I think that that's very helpful as you're thinking about your response, because they do vary by locality. We've also done the math for you so you can see the population rates by race and ethnicity. So it's really a good tool to make simple comparisons. We hope that these and other resources available on our website can help support your COVID response. We feel the recommendations outlined in the emergency operations brief will truly strengthen our public health response, not only during COVID-19, but also during other public health and climate emergencies as well. We are thinking of this as a new standard of practice. We're pleased to have partnered with our colleagues at BARHII to co-develop this brief and to co-host this webinar. Sincere thanks to our presenters for their exceptional work in advancing a new and critical practice of elevating equity within EOCs across their jurisdictions. We have an opportunity to learn together as we transform our own practice. So I'd like to turn it over to Marley, our Health Equity Manager. Thank you.
Before we dive into the conversation with our wonderful group of panelists this morning, and I'm so excited to have so many robust national equity leaders with us this morning to join us in this conversation, I did just want to take a moment to quickly discuss the brief that is a companion to this webinar, which is our Embedding Equity into Emergency Operations brief. And the folks that are joining us for this webinar today definitely served as an inspiration for this brief and have provided a lot of tools and resources that are embedded into this brief. The brief itself contains an overview of the concept behind embedding equity into emergency operations and structures, and includes a series of case studies from 4 California jurisdictions, as well as highlighting the work to embed equity from 3 leading national models in Seattle, King County, Louisville, and Portland, Oregon. Throughout this brief, you can find helpful tools and resources for turning these models and recommendations into action. This includes sample organizational charts that some cities and counties have used to formally embed an equity officer into their ICS structures, as well as sample equity audit tools and community agreements for really authentically partnering with community during public health and other emergencies. Finally, this brief includes a series of priority recommendations that were identified from key informant interviews. These are primarily equity officers and staff who have been officially embedded into their own emergency operations and response structures, as well as a review of available literature on this subject. Next slide, please. And Asma is going to briefly walk you through just a few of the priority recommendations.
Great, thank you, Marley. So as Marley mentioned, what has come out of this distillation of interviews that we've done and the series of literature reviews is really 5 core recommendations that would help take the theory of what is embedding equity into emergency response into the implementation phase. And so I'll go through the 5 very briefly. The first priority recommendation is to create a core equity unit with a dedicated equity staff lead and staff roles around that lead. And so some examples of what that means that we've seen around in both in our region, statewide and nationally, is that EOCs would appoint an equity officer to be the leader of all equity related activities around emergency response. That leader would be surrounded by staff who are full-time, compensated by a full-time appointment to help drive those activities into completion. And these staff roles would be identified ideally the emergency, and activated as soon as the emergency hits. Secondly is providing equity training and capacity building before and after the emergency response activation. And so this includes kind of an inside-outside strategy. And so looking inwards at the team structure, at the department structure in terms of equity training. How well-versed is this dedicated equity staff unit in equity? How well-versed is the leadership in equity, making sure that those two are aligned before relationships can go outside of the unit in order to ensure that the activities are successful. And third is to identify and deploy institutional equity champions for political mobilization. And so this is really about capacity building. It's about political power in order to allow and to amplify the work of the staff in the equity unit more regionally and more broadly. And we've heard a lot from the people that we've been interviewing in these roles that a particular challenge has been where policy plays into this. And so where there is political will in these regions and where there is not to really back these equity activities has been a deciding factor in how successful these activities have been. And fourth is to build and activate community partnerships for responsive equity solutions. And so some examples of this we've seen is identifying community organizations that are on the ground, that have strong ties to the community that the equity officer or unit is hoping to service, and to really compensate them for their time, compensate them for their services, and pull them into the table of decision making. Have them be key partners that are relied on for accurate information and timely information, and also have them at the table for decision making, and so that they're not just informants, but that they're key leaders and partners in this work. And some tools that have been used to ensure that this is the case are things like community partner agreements, and you'll see that linked in the brief if you take a look. And finally is to integrate equity into the recovery planning and implementation process. And so this is more of a long-term sustainability part of the work. It isn't enough to just focus on equity in the short term when the emergency is happening, but how do we integrate equity into recovery once the state of emergency has ended? We know from what Melissa and Tracy have shared that the brunt of emergencies like COVID-19 really falls on communities that are hardest hit, communities of color and Black communities. And so what are we doing to ensure that once the crisis passes, that they are able to get back on their feet and that they are ready for the next crisis when that hits? And so that's in a snapshot. More on this in our brief. And with that, I will give the mic back to Marley so she can introduce our wonderful panelists for the day. Thank you.
So we are absolutely thrilled to have the opportunity to hear from 3 leading national equity leaders this morning. And I do just want to remind everyone that this session is being recorded. And unfortunately, something arose at the last minute and Shakira Simley is unable to be with us this morning, but we will share some takeaways as well from her on this work. And so we're thrilled to have the opportunity to hear from 3 leading national equity leaders that have been working to advance equity throughout the COVID-19 response through their own emergency response structures. All 3 of these panelists have been really leaders in advancing equity and have so much to share. I'm just going to give a brief intro and then I'm going to let them introduce themselves and share a little bit more about themselves and their role. So first, I do want to welcome Dr. Ayanna Bennett, who is the Incident Commander for the Public Health Doc and Director of Health Equity for the Office of Equity for the City and County of San Francisco. I'd also like to welcome Katie Balderas this morning. Katie has led the Office of Equity for the City of Long Beach Department of Health and Human Services since its launch in 2017 and served as the city's first equity officer embedded in the EOC. And then joining us virtually all the way from Seattle, King County, a big welcome to Marielle Torres Medapor. Marielle is currently serving as the equity officer in the county's COVID-19 response, but when not serving in this capacity, she is the Chronic Disease and Injury Prevention Unit Manager. So good morning. To get us started, could you start by sharing a little bit more about how your role has changed since the start of COVID-19 And what was the process for an equity officer being incorporated into the ICS structure in your county or city? And Dr. Bennett, it would be great if we could start with you.
So first, I am not the equity officer. I'm really sad that Shakira Simley is not on, since she was for quite a long time the equity officer for this activation. I think that's an important distinction, and so I'm going to belabor it a little bit. So I'm one of the incident commanders. So the activation is city, county-wide, and Department of Emergency Management, Human Service Agency, and Public Health are jointly running it. So I am the incident commander for all of the public health activities, so the testing and the hospital management, all of that. That is a lot. So my previous role as the director of the Office of Health Equity in the health department is very hard to maintain while also doing this. So I absolutely have an equity lens, but it's impossible for the person directing operations and looking at administration of the incident to actually be the person who is primarily in charge of equity. So it has been a really interesting endeavor to be the equity person in my real job, and to have a lot of those issues crowded out by the gears as they churn. But I do think the experience of having the equity officer did bring back some of that I would otherwise have not been able to capture as well. And it has been really helpful. I will say that the being able to work with the equity officer and figuring out as one of the commanders where that fits in and how to make sure that it actually gets down to the ground has been a real challenge. But that is my role in this, is really to help incorporate what the equity officer brings.
And Marielle, I know that you, Seattle-King County in many ways was one of the first models for this. So we would love if you could give a little bit more information about how your role has changed and the process for embedding an equity officer into the ICS structure in Seattle.
Definitely, and thank you again, everyone, for having me here this morning. I just want to mention that Dr. Bennett is completely correct in that even if you're coming from an equity background, if you're an incident commander or a deputy chief for logistics, let's say, for example, you cannot serve as both at the same time. And having the position of an equity officer as well as an equity team, that your sole purpose is to look at policies or guidance or strategies and really thinking and researching the equity implications of those decisions is extremely important. Our experience here in King County has been, about a couple of years ago, the equity officer position was originally thought of and then embedded within our ICS structure. Last year, we were able to do I guess you could call a test run of the structure when we had both the hepatitis A and measles outbreak here in our county that we were dealing with it. Though obviously the scoping apples to oranges just because of the amount of manpower that you need to be able to address a lot of issues that come up. So one of the things different from last year compared to our response now is that the equity officer role was shared by a number of us, and we oftentimes served in 1 to 2 week duties. We worked really closely with one another, but then we would go back to our quote unquote day jobs. Earlier this year, when we were experiencing the first outbreaks in our county, we quickly realized that that's not going to be able to function well, given the nature of this outbreak. And so I came on board and was deployed to our Health and Medical Area Command, and as equity officer, and I've been serving since. On about day 2, I started recruiting different colleagues, not just from our Department of Public Health, but also from our sister agencies within the county, and really started building a team that has since been comprised of not just county employees, but we do have a bioethicist who's part of our team, who's on faculty with the University of Washington, but he also works very closely and is on the board for a local Korean association. We also have community members that are part of our equity response team. And so it really takes those of us in our team bringing in subject matter experts as needed, just to really attempt to give the due consideration that the equity issues that have come up in the response really merit.
Thank you, Marielle. And Katie, would you mind walking us through some of your experience? I know some of this was done really in the moment, in the heat of COVID-19.
Yeah, for sure. Hi, my name is Katie Valderas, City of Long Beach Equity Officer, and I don't know whose idea it was to put me after King County, because we have looked to King County for so long on so many of your equity efforts that it's really hard to follow. I feel like you are the sages in this moment, and so I really am grateful for all the leadership you've shown in the areas of equity and health equity. So my role is kind of unique. I had a baby 8 months ago, and I was on maternity leave when COVID really started heating up. I remember a moment very clearly nursing my baby in the rocking chair and talking to my husband and being like, I feel like I have to go back to work. Like, COVID is going to be big. Our department is so slim. I adore the work that we do so much that, we agreed. And also just economically, my husband's work was kind of shutting down. And so financially, it made sense for me to return back to work early. And so it was helpful in that because my workload was fairly empty because I'd been on leave for the last 3 months. And so I literally just started showing up where I thought I could be most useful. And at that time, I had a part-time staff person on my team who was doing language access in our Joint Information Center. And so she needed some support. And so I started showing up at our JIC, is what we call it, and helping out with language access and making sure that we were streamlining that process to make sure that all of our non-English speaking communities were getting the information as quickly as they could. And then our health department director, Kelly, had reached out to our management team and asked for some support for her at the Emergency Operations Center. So I started showing up there, not really clear like what my role was or what incident command structures or EOCs were how they were supposed to operate. I think the structure was fairly new to me. And so I learned a lot about the different players. And it wasn't a matter of embedding equity right away. It was really kind of understanding how the ICS structure worked, understanding that COVID, we knew there would be huge equity implications, but there was some learning about the structure that we had to do first. But showing up was really just the first step. Our fire department was really taking the lead on running our incident command structure. And so they typically don't speak the equity language. So Kelly gave a great equity presentation to about 50 folks in our EOC to kind of help them start speaking the language, looking at some of the core questions that we ask when we use an equity lens. And so that got people thinking about how we really embed equity into the structure. And so, we looked at King County's equity annex for emergency response, showed it to a couple of people who were more experts in ICS structure than we were, and they put their heads together, figured out what our structure could look like. We pulled a small team together to help respond. And once we made it part of the org chart, we were included in our daily briefings, asked, questions about testing and communications, and just started to try to raise the equity lens whenever and wherever we could. And so I think, for us, we speak to those departments who haven't formally embedded equity yet in the way that King County has, because we were newer to this, and it was really just a slower process for us to embed it. But now that we're here, I imagine that we'll be incorporated into more disasters moving forward. And I think that is something I really look forward to. Not the disasters, but equity being incorporated.
Yeah, and both that annex and org chart are available in the brief. It's really helpful to see the visual layout of how this works. And Dr. Bennett, I know you wanted to add something about the process for embedding an equity officer in the city and county of San Francisco, if you wanted to add.
Yeah, I focused a little bit too much on my role. I'm going to add something. So I think in some ways we hugely benefited from having a great deal of infrastructure and history around this in the last few years. And it also was part of what made things difficult. So there is an Office of Racial Equity for the city that was established last October. My Office of Health Equity had sort of been running without name and then was established really at the same time. All of that was very helpful. So it was clear who was going to be the equity officer. It was essentially the equity officer for the city, came into the command structure. It was actually really clear where it would be on the org chart because it's essentially a department head, and that meant it was in the command structure as part of the command staff. So she was briefing at the morning and evening briefings every day. And it was fairly seamless because that infrastructure already existed. It wasn't confusing to anybody how to integrate it. And that's the same person who's been working with all the departments around their own equity. The thing that made that difficult, though, is that one, the ICS structure and community engagement structure of equity are not the same and are not necessarily compatible. The ways in which you try to integrate community voice are different than the way you set epidemiological strategy. That is, it's not as much about what would be more palatable or what would be more supportive to people. It's where is the virus and how do we get it, which didn't always match what people's perceptions are. We were in lots of institutions which, for both normal but terrible reasons, are not very visible to community all the time, even when they are related to them. So we were concentrating a lot on the jail. We were concentrating a lot on nursing homes and RCFEs and other places, which in a lot of ways, even though people interact with them, can be very invisible to community. So the things that would be obvious, like being in a neighborhood, were not as important in the beginning when we were sheltering in place. And so that communication that would have been built and should have been built wasn't there as much. We were very successful in getting the virus not to have a huge death rate in our city, but that didn't necessarily show the visibility of community engagement that would really be needed as soon as we ended shelter in place, which is now. But those institutions are all disproportionately Black and disproportionately people of color. So our county nursing homes are all disproportionately Black. We have 4 to 5% of the population, 25% of those nursing homes. Disproportionate in the jail, 4 to 15% of the population, 50 or 60% of the jail. So it was an equity decision to do that and an epidemiologic decision to do that, but it was not traditionally the venues in which our equity work for the departments operates. And so I think a lot of the relationships that are established weren't super useful in that phase. And the lack of relationships that, chickens coming home to roost, the lack of infrastructure and relationships in the community that has been a long-standing problem for the city suddenly became much more problematic when you need that community agreement for urgent health needs. So we both couldn't lean on it when we were doing things that were not really the traditional equity frame, and also didn't benefit from a long history of community improvement, lots of departmental interaction, and we all worked well together because we've done a lot of that recently. But that's very different than the community interaction building, which the equity officer was quite good at helping to build, but that the distrust and others with the other institutions that were having to work, fire, public health, all of those institutions which haven't had the best performance in communities of color, all had to live with that lack of trust in trying to do their work, which is completely valid, but not something that any one person or even a team of people can magically make go away.
Great, thank you so much for offering that context. I think it's extremely important to kind of highlight how important it is that all parts of the system are working together and that there is a pre-existing structure for this to happen successfully. Like you said, it can't magically happen, especially not during a crisis. So thank you for that. We'll move on to the next question, and I'll have Marielle start with responding. And it is, what successes have you had as a result of equity being intentionally embedded in the EOC and ICS structures? Go ahead and take it away, Marielle.
Thank you. I think the fact that we were able to pivot really quickly and build a team as opposed to having individuals provide support, I want to call that a success, because in the moment of a crisis, to be able to have flexibility in your structure again, I want to say Dr. Bennett is correct. Equity work and the ICS structure as it is are not necessarily compatible. The way that we work with community and engage with community is not necessarily, has not historically been compatible, right, within an ICS structure. And so I think that, from the very beginning of our response as a county, even outside of our equity team, there was consideration made with how we needed to work with community. Again, I always want to give the caveat that, our processes are not perfect. We do have, it's a balancing act because some of our departments, as Dr. Bennett mentioned, do not necessarily have the best of relationships with community. Even historically, public health as an institution has not had, great relationship with community. You have to really work through that. Our department and our county has been doing a lot with that in mind. But in the event of a crisis, it becomes even that much more important. I do want to say that they're, really looking at how we operationalize equity so that it's a foundation of our work and not an afterthought. And that it's everyone's responsibility within a response and not just that of an equity officer or equity response team, or the people of color who are making up different components of response. That, I want to call that a success. We're in the, the next phase of doing that type of incorporation within our HMAC structure. But it's one of those things that in the moment of a crisis where people can say and that there's a lot of work and that they have to put out a lot of fires. The fact that we are working hard towards ensuring, again, that equity is the foundation of our work and being done by everyone, I would count that as a success. A few other things, just the really, the way that we have processes. So our equity team at the height of the outbreak here, in the sense, early on of the outbreak, we were meeting 5 days a week for about an hour and a half. So Monday through Friday for an hour and a half, which allowed us, again, that flexibility in being able to look at things real time as they were coming up and providing guidance and feedback. And one of the things that we noticed, or that we were really concerned early on, is even though the recommendations had not come down with regards to mask wearing, we were concerned with regards to what the implications of the potential requirement of using masks as a mitigation factor would be on our communities of color. And really started highlighting that not just within our HMAC, but we have what we call Policy Thursdays in our meetings, where a member of our HMAC policy team joins us. And what was, it was serendipitous, but also, I guess, part of our structure is that we had just had a conversation with Susie, our policy colleague, with regards to masks. And next thing we know, the county executive was looking towards drafting a mandate for mask wearing. And we were able to work with our policy and with the executive's office, as well as with, there was participation and comment and a lot of feedback from community partners, as well as our pandemic advisory group, which also has community member representation on how a requirement or a mandate was not in the best interest of our most vulnerable communities. And so it did become a directive at the end result, which was, I think, just a lot of work that was done behind the scenes, not just by our equity team, but by a lot of community partners as well. And so I'm just really looking at that way of just, what are the opportunities, but also trying to make sure that our structure is set up in a way where we're not losing those opportunities, right?
Great, thank you so much. Katie, would you like to highlight some successes at Long Beach?
Yeah, in terms of successes in Long Beach, I mean, I think, again, this was all fairly new to us, but once we started showing up, I think language access was a first priority to make sure that our press releases, our website, our health education materials, social media posts, everything was done in Spanish and Khmer. And Khmer is the language that our Cambodian community speaks, which we have a very large Cambodian population. And so that was kind of first and foremost our entry point to really addressing equity. And then once we started being part of the daily briefings and learning more about how testing sites were being run, we started asking questions about like, okay, who is left out of these drive-up testing sites? And we know that mobility and access to a car is disproportionately has impacts for our communities of color because they're more likely to not have cars. And so we, our planning and testing crew was able to set up walk-up testing sites at most of our facilities. So that was one early win for us. Later on, they were able to mobilize testing for people who are homebound, older adults, or congregant living where testing was not being offered already. And they did mobile testing based upon request. And then another cool win that I love to share is, we have somebody on our team who has worked a lot with reentry population, and knowing that a lot of our jails were being emptied, she brought up the point of, if for those people who are going into congregant living, halfway houses, sober living homes, they're kind of under our radar because they're typically smaller groups of people, and they're not nursing homes, but they are at high risk, and they are, disproportionately communities of color. And so how do we make sure we're reaching them? And so we had someone from our Intel team literally go through the yellow pages to look for sober living halfway houses, looking on Craigslist to find those. And they developed some education materials specific for those populations, did some direct outreach. And I thought that was a pretty cool way to reach people we wouldn't normally think of otherwise. Currently, our equity team is working with our Pacific Gateway workforce agency to bring in some ambassadors to do some business outreach that is both the intersection of business supports as well as health education, getting some materials out to communities, and also a way to provide some youth employment opportunities. And so we have a team of 8 young people who are going out and doing that. And I think, one of the things that I forgot to mention is since the Office of Equity started in the health department, I've been mostly an office of one. I am the only full-time person in the office. And so I have a couple half-time people. But this was an opportunity as rural disaster service workers to really pull from our pool of talented community embedded staff across the city. And so we were able to pull together a team. And I love the fact that we were able to mobilize it so quickly, because we pulled a community relations manager from the port who grew up on the west side of Long Beach, a community of color that has high rates of poverty. We pulled someone else from the health department who has worked on human trafficking, gang violence prevention, has a ton of deep relationships, worked for the city forever, knows everybody. And we pulled our Black infant health coordinator into our team. And so all of those people came with lots of relationships, lots of knowledge about different disparities in our community and things that I wouldn't think of on my own. And so that was the beauty of being able to mobilize this team, because I certainly could not have done it alone. Once George Floyd was killed, we did have to pivot to focus on the uprisings against racial injustice. Our city council directed us to focus on a racial equity and reconciliation process that has really taken us a little bit away from COVID specifically, but in all of the engagements we were doing with communities of color, what we kept hearing is systemic racism is the through line. It's what connects disproportionate outcomes related to COVID, and it's what to the uprisings against racial injustice. And so I don't untangle those two things very easily. And so it's really important, I think, to name that. And with all of that community engagement we did with COVID, it has really led us to a point where we have a lot of community relationships about how we do things like investing CARES Act dollars into communities of color, how we are focusing on, this reconciliation process to address racial injustice. And so yeah, I think those are some of the other wins. We're also using tools like mapping to understand where our outbreaks are, where deeper investments need to happen with regards to contact tracing and community engagement efforts. So those are some of our wins.
Great, thank you so much for sharing. And Ayana, I'll look to you to share some successes from San Francisco. Oh, you're on mute.
I'm a slow learner because we've been at this for months and I still do that. Two things, and neither of them, I think, was as clean as they could have been. But the first is that both the equity officer, who was, I don't think it was Shakira Simley anymore at that point. I may have been Brittany Chicago. I'll think of it. Really pushed the idea that that we had to say something really directly about the role of systemic racism in this epidemic. That was probably a month before George Floyd was killed. And we did that in two ways. The first, I think I was the impediment to having it just be from the emergency management center, because I wanted it to be bigger than that. So what we did from the COVID center is do a health advisory to clinicians and health systems that they should be taking a different approach to people who had really a higher risk of transmission because of the way they were being asked to live in crowded conditions, and had a higher risk of severe disease because we already knew nationally that communities of color, particularly Black people, were having disproportionate deaths. Both of those things really did require that people approach differently their sense of how progressive this disease would be in terms of checking up on people, who you would test, making sure you're testing their family, all of those things. So that was done fairly early on. But the even better part is that the equity team, once back at the Human Rights Commission, because people have been cycling in and out, were able to take that and make it a declaration from the Human Rights Commission and a matching declaration from the Department of Public Health, much more broadly, that systemic racism was a public health crisis and that this was just part of it, which I think is a good way to move this beyond the immediacy of COVID, because it really is just COVID uncovering things. COVID didn't create any of this. It's just uncovering problems that we've allowed to stand for a long time. The second is, I think, a little more fraud example, but I'm going to do it anyway. So when we were in the once shelter in place went off, we've had a really sharp increase in cases. And that was something that I think our data systems were not as good at seeing at first because they were so heavily geographic. They were micro. They're not even neighborhoods. They were census tract level, because that is the way our segregation has worked in this city. There are these pockets of extreme poverty surrounded by relatively less poverty, and then whole areas of affluence. Because that is true, our initial data work was all much broader and citywide, and a little bit of it went down to the level of large supervisor districts, but we weren't really at the micro level. And it really was the push for community for their own data, and the fact that they did not mean just divide by ethnicity. They wanted to know how their particular community was doing, and that definition of community could be really geographically compact and small. And then so that we started to do that data, and it really did reveal that we didn't have an outbreak in this area, and it didn't look too bad in this broad area, but there was a hyper outbreak in these 10 blocks of this neighborhood that circles around a public housing development. I think we probably would have gotten there, but we wouldn't have gotten there in time, and it wouldn't have been as immediately useful if we were starting it late just now as the disease has pushed us to think that way. I think because we had done so much of that coding earlier to answer that demand, it took forever. So people thought we were taking way too long, and they were right, but it was just difficult to do with the quality of data that we were getting. But having done all that work beforehand in order to answer that request, which was very strongly carried by the equity officer a lot, if we hadn't done that, we would have been way behind the 8 ball right now. So I think that it was really helpful. Their intention was different, but it was important in both ways. It was important for them to know in terms of equity, but it's also strategically important because this is so tied to our segregated racist past. So it is all of our history is being laid bare in this. That means that the disease is laying itself all across the bones that we've left. So we have left segregation, pockets of poverty, geographically limited areas of low resources, because we've made it constructed that way in our society, and those are conditions the disease is attracted to. We have made the disease this patchwork. And that is just how it's going to play out in a country that is designed in the way ours is. And because they've forced us to recognize and acknowledge that from early in the engagement, it also meant that we were following the reality of the disease before it was even clear that that was the reality of the disease. And it should have been clear, because that's the reality of everything in health and how it works here, because it's just too endemic not to be the origin story of all of our problems.
Yeah, thank you, Dr. Bennett. I think all of us that have worked in equity in a government setting understand that community voice and organizing has been so instrumental in allowing us to really have a robust equity presence throughout the state. And so some of you have already spoken about this, but could you highlight some ways you've been able to advance equity with community in response to COVID-19? And so can you give us some examples of how community has been authentically integrated into leadership and decision-making positions or the process during your response? Some of you have already spoken to how you've partnered, but Marielle, I was wondering if you could start us off, because I know you shared some amazing examples of some of the work Seattle-King County has done to formally integrate community into that decision-making process.
Sure. And, I think, again, looking at, our experience here in King County is a little bit different in the sense of, like, we were the first spot in the country to have an outbreak, and it affected our long-term care facilities first, right, with the, but even with that initial experience, many of my colleagues within the response really looked at how do we build in community, not just participation, but community being involved at different levels of our response. And so I want to take our pandemic advisory group as an example, which is an advisory body that has provided input in different areas such as CARES Act funding and where it should go, with regards to different policies as well. And we have community members that are community leaders that are part of that group. We also have, looking at our numbers, where we want data to be our guide. The unfortunate reality of who is being affected by COVID right now, it just as Dr. Bennett and Katie mentioned, we're really looking at communities that typically have disproportionate impacts with any health issue. And so the Latino community, the Latinx community, is 10% of our population here in the county, but they're about a third of our cases. And so, looking at how can we improve our efforts within the Latino community. And so, we stood up a COVID Latinx community response planning team where we have community leaders, community members that are part of that group, working with fellow colleagues of mine and myself, and that we also then have built in weekly community meetings, community calls, where it's not just information that is being provided to community, but it's a two-way conversation, right? Because we're also learning about what's going on. We haven't limited it to just King County folks. We do it via Zoom as well as Facebook Live, so we do have representation from other parts of the state. But really looking at how do we make sure that our response is being guided by information and guidance of the community. We also have, with our contact tracers, very early on, we've had conversations. I had conversations. Our team had conversations with colleagues working on contact tracing of, if we wanted to be successful there, we needed to make sure that the workforce was represented of the communities that are being most affected. And so, you know, even though the workforce is still growing, you know, my colleagues in that area have done a really tremendous effort to make sure that in our recruitments that we are hiring contract tracers that are of the community, and also working with community partners and community organizations to make sure that we have, you know, that we're building that trust with community. A good example of that is with the Marshallese community in our county, where they are disproportionately affected as well with regards to COVID. But there was just this huge gap with regards to how they were being able to access testing and care, and just a mistrust of the system. And so, you know, my colleagues are working, and we're able to contract with the Marshallese Women's Association to really, again, build that trust, to provide the wraparound services and access to care that the community residents deserved. And so really looking at, you know, again, those relationships, and, you know, trying to make sure that our strategies are leveraging the relationships, but we're doing it in a way that is honoring the work of our community partners, making sure that they're compensated and that we're not creating extra burdens on them.
Thank you so much, Mariel. So many amazing examples of just the ways that you've partnered and compensated and continue to think through authentically partnering. Dr. Bennett, were there some additional examples? I know you've already highlighted a few ways community voice has been integrated into your decision-making process, but any other examples that you want to highlight here?
Oh my God, I learn. I'm capable of learning. So I would say, first of all, I wanted to just remember that it was Brittany Chikwata and Zaya Malawa who were integral in that first structural racism health advisory, and then Brittany pushed forward the declaration about systemic racism as a public health emergency. So just wanted to give credit where it's due, because that was not me. I think one of the issues that we've had is the difficulty in integrating community voice. The equity officer has been able to push forward some things, and I think there have been some really fought for successes on that side, but they were probably far more difficult to get integrated than they should have been. So I'm not sure that when people have to get to the point of yelling at you, that you get to call that successful integration. But we did do what we were yelled at to do eventually. What I think is the problem, so I'm going to focus on how this could be better. The agencies that are part of this particular endeavor and emergency management generally, fire, police, emergency management, are not the same agencies who tend to have long-standing relationships with community. Those agencies, Children, Youth, and Families, Human Rights Commission, workforce development, those are not exactly the agencies we called on in a pandemic to say, help us lead this engagement. And yet that left out a lot of staff with a lot of skills and whose networks might have been really helpful. We're trying to correct that now, and those may not be the staff whose job it is, but we have lots of real leaders in the community who happen to work for the city. So we're trying to start to integrate those people, and that will be really helpful. It is almost impossible to really integrate the voices of people who are not present here. It is I tell everyone, it's drinking from the fire hose. Don't think you'll know anything the first day. It's just chaotic and crazy, and things change really quickly, and everybody's responding to a different stream of information. It's just difficult to try to integrate something from the outside to that without some kind of real strict infrastructure around it. I just don't think that's possible. And without the equity officer and some of the work that had been done, I don't think we would have been able to do it at all. It's just impossible to really get the dialogue without that, even by well-intentioned people. But bringing in some of those other agencies, as we now know, this is going to be a long-term thing. It's not going to be like an emergency where the fire department gets the ramp up for a couple of weeks and then go back. This is clearly going to be months upon months upon months. It's really more like setting up a new department and programming with that department than it is like running an emergency. But that means that we need the people whose job it is to do that kind of long-term engagement. So we're starting to engage with those departments to bring them in. It's easier to train someone from youth and families about COVID than it is to train someone who knows a lot about COVID or emergency management about community engagement. So trying to flip that script for ourselves about who the right people are to be engaged, I think is going to be really important. I'm hopeful that that will improve things.
Yeah, thanks, Dr. Bennett. I think that leads us really well into Katie, because you were speaking to sort of some of the similar things Dr. Bennett was highlighting about bringing in your partners, the cross-departmental partners that really do this deep work with community, are from communities that are disproportionately impacted by COVID. So is there anything you want to add about some of the ways, additional ways you've been able to integrate community leadership and decision-making into the Long Beach process? I'm unmuting you, Katie.
Okay.
There you go.
Thank you. I just want to echo everything she just said. This is an area of growth for us. I don't think we are at the point where we could claim to have shared leadership and decision making around this, but I have been taking notes because I love the idea of the pandemic advisory group. I think one of the limitations for us is we strongly do believe in compensating community for their time, and we did not have the funding or infrastructure by which to do that right off the bat. And so I think, with CARES Act funding, we do want to infuse community groups to be helping to guide us, inform us, and also be doing the work that they're already doing. I also wrote down the phrase drinking from a fire hose, because that's exactly how it has been. And I think we have been more reactive to community yelling at us around the data they need, the solutions they need, than we've been able to be proactive, because it's just a matter of our capacity being so slim as a department, even when we're not in COVID status, and then add a pandemic to that, and we're just drowning. And so I underscore what she said about orgs that have been leading us in ICF structure not traditionally having the longstanding relationships with community, but also the ones who do have longstanding relationships with community, their capacity has just been really slim. What we have done that I think has helped us, we've done some really language-specific, cultural-specific education forums. We started off with an African-American panel, and then did some further smaller group listening sessions, focus group style sessions, to really help guide us through some of the outreach that we needed to be doing. We also did some focus groups or listening sessions specifically with our Latino communities, one in Spanish, one in English. And one of the things we heard from the Spanish specific one was there's a strong fear, and there's always a strong fear about family separation, but I think it was more specific to if families were testing positive due to COVID, people were afraid they would be deported or their children would be taken away. And so we partnered pretty quickly with LA County Department of Children and Family Services, who put out some pretty immediate communications around that not being true, at least for the case of family separation if you get tested positive. And so I think, anytime you engage community, you really open yourself up to some really hard conversations about how they feel marginalized, how they feel ignored. And so we've really had to lean into those conversations and not, say, thank you for your feedback, see you later. And so, our Cambodian community in particular has been very, very clear, like, yes, we want to do this forum with you, but also we need a long-term commitment from the city because y'all have left us behind and we deserve more, we demand more. And so we've really been embracing those hard conversations and really trying to figure out how we invest in them. And part of that is out of our control, but it's also connecting them with opportunities where they can advocate for the larger systemic change that we want to see in partnership with them. And so, that's all I have to say. I think, we really lean on our experts in King County and San Francisco and are looking forward to growing in this area.
Thanks, Katie. I think something that we learned from speaking with all of you and other equity, leaders when making this brief is that this is really a long-term process. So a lot of this you all have had to build in the moment in response to COVID, but it's really laying the foundation for, when we eventually are able to move into the recovery stage, making sure that equity is centered, and then that equity is really foundationally built into our future response efforts and really holistically embedding community leadership into that. And so the capacity issues are so real, and we really appreciate all the authentic and honest responses here today, because I think we're all feeling that. And so I think we're going to open it up to maybe 1 or 2 audience questions. Asmad, were there a few that you want to highlight?
Yeah, I'll start with one. It's kind of a 2-part question, and I've merged 2 of the questions from the chat into one because they're related. So for the panelists, what are some key qualifications for an equity officer or equity team? Do you recommend seasoned leaders? Is the skill set required for an equity officer going to change depending on the nature of the emergency? And this person provided some examples of contrasting what it would be during a pandemic versus fires, wildfires or earthquakes. And so 2 parts, and I'll let whoever wants to jump on the mic first get to that question.
I'll try. So I think I am sort of an equity officer for my department. I think the difference is that equity is about changing culture and about changing people's vision of their world, which are neither of those things something that can be done quickly and without personal relationship. There's always structure to be built. There's no sustainability without infrastructure, so I don't want to downgrade that part, but it does require some interpersonal relationship in order to be of any effect. The equity officer having those interpersonal relationships with departments to be able to speak truth to people in a way they can hear, with the public in a way to be able to really engage with communities in truth, I think it's absolutely required, whether it's the pandemic or not. But the requirement to be able to build those and the expectation that if you don't have it, you'll just build it, is really hard to operationalize during an emergency. So communities where there wasn't already a relationship, or organizations or departments where there wasn't already that groundwork laid, I think it's too much to ask that person to really be able to move those people and have them use their own lens to improve their work. So I think there's a little bit more of a push to it than you might otherwise do, because normally to get some sustainable change, you really need to move the person. And in this case, I think there's a level at which you just have to declare that's not okay.
I'd like to add a little bit more to that. I think it's not just the skill set of the equity officer. Dr. Bennett is completely correct in that it's those soft skills. It's not so much topical, but it's being able to have conversations and leverage, again, relationships to really change the culture. But I think it's also in part with the leadership and what kind of values do you have within that ICS structure, right? And so one of the things that we were able to do, and our equity team was able to help guide our HMAC, is to really write down and lay out those principles that we had for equity. And I have to give many thanks to our leadership for their support, but also in laying out the expectation in that that in all our different lines of business in a response, to make sure that we are adhering to those principles. And it's one of those things where it could feel overwhelming to people, so we're not asking everyone to do it all at once. But of guiding those conversations of, okay, where can we start? Where in identify a strategy or a line of work that you're doing, and how do our principles, how are they reflected in that line of work? And so I think having that type of framework is helpful to me as an equity officer, and is helpful to the equity response team to really, work on guiding and providing the technical assistance that our response needs when it comes to trying to operationalize equity.
Katie, I think you're muted. Yeah, there you go.
I agree with everything that's been said. I think, for me, as I think about my dream team, my dream equity team in the EOC, I think there are a variety of skill sets. I certainly don't have all of them. And so I think it's important to balance out your team with those skill sets. Data is one of them, someone who understands data, I'm not super wonky on data by any means, but I can look at it and my goal is to always make sure that community can understand it and has access to it, and that it's meeting their needs. Relationships, someone who has relationships not just with the community leaders, but the grassroots folks on the ground, because I think you'll often find the richest information, the richest work happening there. Communications, I think we have seen a lot of really problematic communications coming out around COVID in some really subtle ways. And so I think it's important to have someone embedded in your JIC who understands that you have to have really a keen eye for how we're telling a story around, underlying health causes versus just saying that people are dying disproportionately because they're Black and then leaving it at that. I think there has to be a strong equity lens applied to communications. Health educators, I think, have a lot of these skill sets, but health education, people who know how to instill some behavior change on a community level are really important. And then your policy people. And I don't think that any one person has all of those skill sets. And so I think it's really important to build out a team, get them in the right places and make sure that they feel empowered to speak up. I also think group facilitation, we've had a lot of meetings with community via Zoom, and it's been clear that group facilitation is an important skill that needs to be built out. And then I'd say, the overarching values that I think need to be included are a strong sense of humility and having the growth mindset, because we are learning so much, and we have to remain really flexible, adaptive to everything that we're hearing and learning as we go.
Thanks so much, Katie. And Dr. Bennett, did you want to add one more thing?
Yes, I just want to be sure also that the person really does need to have a systemic change lens, an operational lens, because I can't imagine there's a place where they won't be working with a lot of people who are new on their equity journey. And I don't know if it's just a national character, but people I find who are new on their equity journey tend to overemphasize feelings and communication as the problems in any environment. They are absolutely important, but if we communicated badly but gave people the resources they need and answered all their requests, they wouldn't care as much. So it is just getting to the brass tacks that people aren't getting their mask or their food or whatever it is they need. And it is really hard sometimes for people to admit that equity is actually about not getting stuff, that it's not thoughts and prayers, and they can't just be nicer. So getting people past that really requires that you yourself have a lens about what it means to do something equitably, not just what equity means in some kind of soft fashion, which I think is where a lot of people are stuck, especially in the beginning. And it's going to take someone with a real lens to push them past.
Dr. Bennett, we have a couple amazing quotes from you this morning that I'm going to have to go back and pull out. I loved that. And I think we have time for maybe one more quick, maybe from Dr. Bennett or Katie, quick question sort of related to the state's role. So how, if at all, can the state government, because we know that we're talking with folks that work at the local level, so how could the state government support this process of embedding equity more intentionally and better supporting community in the decision-making process? Is there a role for the state here that you think would be helpful with your work? And maybe Dr. Brown, Katie, since you work in California, one of you might be able to chime in.
Can they fix their data? Like, really, please? One, can they disaggregate Asian from Pacific Islander, which they've known they needed to do for 10 years? It's been law for 7 or 8. It drives me bananas because they are not the same. And the second is the racial and other demographic information that the hospitals and testers are giving them is terrible. They're not necessarily enforcing that people give them better data. And a lot of the data that I need, they're not even requiring to get. So they have power that I need them to use because trying to get those things fixed on a local level is really hard. Telling a lab that they have to do something that the state's not making them do, we've done it, it doesn't work. is just really hard, and I need the data. I need to know who's getting tested where, what their racial groups are. I just need to know it in order to do a good job. And they're not letting me do that. Please fix the data. That's my only thing.
Yes, fix the data. Add sexual orientation and gender identity in there too.
Yes.
That should be a given. And, you know, also, God, the state just needs to invest in health departments having equity like baked in, and you know, supporting equity officers, because ours started with a grant from California Endowment, and now the city has to fund it. And it's like one of the only structurally funded positions in the health department. And so I think the state could really benefit from embedding or from investing in more health equity infrastructure in health departments, the same way they have with Black Infant Health and with WIC and with other programs.
If I can add one thing there, even though I'm hearing in Washington, but I worked for many years in California. I have to say amen to what you guys have said, because I mean, some of those challenges we see here with data as well in the state of Washington. But I think it's also, you know, it's a reflection of the underfunding of public health. You know, one of the things that this pandemic has just really also laid bare is how by underinvesting in public health, we leave ourselves that much more vulnerable to outbreaks. And, you know, typically what happens is when there's a budget, quote unquote, budget crisis, is one of the first places they look to cut is within the realm of public health. And so I think that it's, you know, it's really another call that if we want to have robust ability to respond, and not just to disease outbreaks, but to really respond to this question of racism as a public health crisis, we have to make sure that we're funded in a way that we're not dependent on grants, right? Because what happens, you get a grant, you get started, and then your grant funding goes away and you're done, right? And you don't have any ability for sustainability. And so we really have to look at, you know, especially with a lot of the conversation that's being had on defunding the criminal justice system, where are we putting those dollars in, and what are we wanting to support, and how can we do it in a way that we're going to be able to create that sustainable change that our communities need.
Yeah, thank you so much, Mariella. I think that's actually a wonderful way to close the panel, because we know that our public health infrastructure has been systemically defunded for decades. And what that really ends up meaning is that, you know, our communities that are most vulnerable to the impacts of COVID-19, our Black, Latinx, Indigenous, Pacific Islander communities, are also being disinvested from. And so it's really important to close with making sure that we are advancing equity and also advancing really the critical funding we need through our public health infrastructure, which means also investing in our communities. And so thank you to Lauren. She shared a document if folks want to learn more about the way that our local health departments have been defunded and the impact that's had on this response. You can learn more from that as well. So I just want to take a moment to thank the three of you so deeply. It's been incredible to have you here. I know you're all insanely busy, and so it's just been an amazing opportunity to get to spend an hour with all of you in conversation with you. So thank you so much for your time. And we will capture the questions that we didn't get to today in the comments and try to make sure we're able to answer those and get feedback from Katie, Marielle, and Dr. Bennett on those questions. So thank you so much to the three of you. We really appreciate having you here today. We are just going to close out with a few closing words from Melissa and Tracy about some next steps and ways that you can support this work moving forward. So Melissa, did you want to start us off?
Thank you, everybody, for your time today and for the panelists for such a frank conversation. So the way we work at BARHII is we have large events like this one that share information about what's happening in the field. And then we do very focused support to the public health departments in the Bay Area that are seeking it to help put these ideas into practice. So if you're interested in figuring out how to integrate more equity into your COVID-19 response, if you're interested in determining how to get a health officer or an equity officer into your COVID-19 response, or in thinking about once you have an equity officer, what should happen next. We're available to you for that. You can reach out to myself, Melissa Jones, and my email's here, or Asma Day, who's been facilitating the session here today. Her email is also there on the line. In addition, the Public Health Department of the Public Health Alliance of Southern California and BARHII work together on a variety of issues, including policy issues that I'm sure Tracy will talk to you about more in a moment. And those include things like access for public health funding and making sure that communities have what they need in what is a dual health and economic crisis for folks right now. So thank you so much for being here. And Tracy, your shot camera on.
Thank you, Melissa. And thank you so much to our speakers. You're all such visionary leaders in this work, and we're really fortunate to have had the opportunity to learn from you today. And we so appreciate your honesty and your insights. I think it's really breathed life for all of us to really see how this can work for each of us. I'm so pleased to hear that the issue of public health infrastructure was raised. I do want to piggyback on the fact that not only do we have the brief that the Public Health Alliance has just recently released on this, it's actually a full report. And in addition to that, if you go onto our website, you'll see a series of talking points and slides. We're trying to make it really easy for people to advocate and to talk about these things, and we hope that that'll be useful for you. So we know that COVID has exposed, the urgent need to rethink business as usual and to emerge from this crisis a better and more equitable California. I hope all of you are feeling as inspired as I am to think even bigger about what it means to truly advance equity for all members of our community, and what, as Dr. Bennett was saying, what it looks like to transform our systems and structures to more truly reflect and respond to the needs of community members most impacted by inequities. We hope all attendees are taking something away from this conversation today, and that you'll have the opportunity to learn even more about the strategies and practices in the brief. I also want to invite you to become more involved in the Alliance's work as well. We also can provide coaching for those that are interested in embedding equity into their local health department works. We'd also encourage you to take a look at the Healthy Places Index. We're actually having some improvements and enhancements on our website coming soon as well, but you're able to look a little bit more at the local impacts for race and ethnicity. As the speakers highlighted, we're at a critical moment in history with the COVID pandemic and the movement for Black lives. In this moment, a diverse cross-section of Americans are demanding change to acknowledge and rectify the deep structural inequities in our nation and in our governmental systems and structures. We know that embedding equity into emergency operations is just one step, but a critical step in our work towards dismantling those systems and structures as we look to build a more equitable California. We have an incredible opportunity to work together to chart a new path forward where equity is central to all of our decision-making and actions. Thank you so much for attending today's webinar, and we hope to continue to work together to emerge from this crisis a stronger, more equitable California for all. Thank you.
Great, thank you so much, Tracy. And in the last minute, I'd love to invite folks to fill out a poll. I do want to echo my gratitude to the speakers today, to Tracy and Melissa for your great leadership on this work, and to all of our back-end support today. We have quite a few people making the technology of today seamless and possible. So thank you to everybody. And Siobhan, when you're ready, please administer the poll. We look forward to sharing the resources with you all, and thank you again for joining.